Hi, everyone. My name is Elizabeth, and today I'll be presenting my ongoing master's work conducted at the Psychedelics and Contemplation Lab here at McGill, conducted at the LDI. So I am supervised, as Vincent said, by Professor Kyle Greenway, and the core research team for this project is very much Kyle, myself, and Dr. Sarah de la Salle, who's here as well. So in January of 2024, the NPR published an article titled "The Ketamine Economy: New Mental Health Clinics Are a Wild West with Few Rules." The tagline further stating that dosage and safety measures vary widely at the hundreds of ketamine clinics that have opened. At the time of publishing, this article estimated there were around 500 to 700 ketamine clinics across the United States. And 2 years later, what do we think that number has jumped to? 2, maybe 3 times as many? Well, recent estimates guess that there are around 2,500 ketamine clinics operating in the United States. While Canadian numbers are more modest, this site has located 38 psychedelic therapy centers across Canada. Our numbers are also on the rise. For instance, at Messina, a company that offers psychedelic treatments, announced that they'll be opening 13 psychedelic clinics across Canada. I chose this article reporting the announcement to highlight not only the industry's growth, but also just because I loved the image that they've chosen to illustrate this. The description of which says an AI-generated depiction of a patient about to receive ketamine solution orally. What I love about this image of an AI lady with an eyedropper full of ketamine and a patient with 6 fingers is that it forces you to go, okay, but surely that's not what psychedelic therapy is, right? Like that's not what they're doing at these clinics. Wait, what exactly is psychedelic therapy again? And while finding a straightforward answer to this question isn't actually that easy to do. The broad definition of psychedelic therapy, and the one that we use ourselves, is a therapeutic practice that combines conventional psychotherapy with the administration of psychedelic substances. But even this definition is a little bit foggy when we get curious about what exactly happens during therapy. What does the psychotherapy look like in this context? Is there variation in the experience and duration of different substances? Or what exactly is going on during administration? In truth, psychedelic treatments offered in clinical and academic spaces vary greatly in terms of substances, modalities, and modes of psychological support. The number and duration of dosing sessions, the location, training and credentials of providers, the list can go on. As a relatively novel treatment, it is understandable that there is heterogeneity in how we practice psychedelic therapy, but this does present challenges when making claims about efficacy, safety, and the replicability of psychedelic therapy. At some point in the future, it could be ideal to have more standardized procedures for how we actually conduct this therapy, but the major issue that exists right now is that we don't even know what people are doing. Studies that are published today, as well as the myriad of private clinics seeming to open daily, often only describe the substance and the dose that are administered, and rarely other extremely pertinent elements of treatment. These elements can vary so greatly that if it weren't for the shared quality of administering a psychedelic substance, we'd probably consider them entirely different treatments. For example, let's remove the psychedelics for a moment and just imagine 2 therapeutic contexts. In the first, a patient sits in a hospital room and engages in talk therapy with a psychiatrist. In the second, a patient is out in nature listening to a curated music playlist designed to take them on an emotional journey. If an empirical study demonstrated that one of these therapeutic scenarios effectively reduced depression symptoms, would it be fair to make the claim that the other is equally as effective? Now let's add in a psychedelic compound that magnifies the emotional experiential effects of these environments. And even if these patients take the exact same dose of the same compound, the interaction between the person, the drug, and the environment can give rise to wildly different experiences and potentially different outcomes, despite all being lumped under the blanket term of psychedelic therapy. Now, these 2 examples really highlight the significance of environmental factors, but factors affecting efficacy extend to include things like patient psychiatric profile and demographics, the therapeutic alliance, and the patient's subjective experience of the session itself. But these factors are also very rarely reported. Okay, so we've established that if we ever want to make sense of the rapidly expanding Wild West of psychedelic therapy, researchers and practitioners need to be more precise in their reporting practices. But when you take a moment to consider all the possible variables that are relevant in understanding what is safe, effective, how, and for whom, well, what exactly are people supposed to report? If that seems like an ambitious question, considering just how many variables could play a role, you are correct. And that very ambitious question is the focus of our project, essentially finding a way to properly ask and ideally answer what variables should be collected and reported on during psychedelic therapy. So let's start with this first part. How do we even ask this question, or who do we ask? For that, we are using something called the Delphi method, where you pool a group of experts from a given field, in this case psychedelics, and ask them iterative rounds of questions and have them engage in pseudo-anonymous debate with the goal of converging on consensus on a given topic. For this study, our goal is to take that huge nebulous idea of all the variables that one could possibly collect and reach expert consensus on a hierarchical list of the most important variables to collect during psychedelic therapy. So we recruited 78 experts from 11 countries and included psychedelic clinicians, researchers, and health policy experts in our sample to really try and capture the scope of the field. So the core of the Delphi method really is this iterative process where you use the results of one round to shape the structure of a subsequent round. And you want to start as broad as possible with that first round, such as asking, what variables do you think should be collected? And then get more and more specific and nuanced as you go, with later rounds potentially asking something like, if you had limited time to either collect this data or that, which would be more important to collect? So we've just finished up the second round of a multi-round Delphi, so I'm going to walk you through both our process and some of our findings. And it's not clear just yet how many rounds total this will have, as it really depends on how quickly consensus is reached. So we essentially had three main goals for round one. The first goal was to define time points for data collection, or ask, at what points throughout the therapeutic process should we be collecting data? Second, to identify important factors influencing data collection, or ask, what are the most important factors when determining if, when, and how data is collected? And the third and largest part of this round is to generate an exhaustive list of all the possible variables our experts consider important to collect. For the sake of time, I won't go too in depth on the methods of goals 1 and 2, but briefly report our findings. So for goal 1, identifying time points for data collection, we presented experts with 4 possible time point schedules, organizing data collection either by treatment phase, by timing, by visit type, or by dose. And results showed that experts agreed that collecting collecting data by timing and or by treatment phase were preferred to collecting by visit type or by doses. For our second goal, participants were asked to write an open text response identifying the most important factors influencing the design and conduct of psychedelic data collection, specifically factors influencing if, when, and how it is collected. Qualitative coding yielded 4,600 words that we then organized into 23 unique data collection factors, the 3 most frequently mentioned factors being operational feasibility and resource availability, participant burden, and the study objective. Finally, our third goal was to generate that exhaustive list of all the variables experts consider to be relevant to collect during psychedelic therapy. To both orient our participants and attempt to capture the breadth of the field, we proposed 3 distinct yet common purposes to collect data: guiding therapeutic practice, academic research and knowledge development, and economics and health policy purposes. We also checked if experts thought that these purposes were appropriate, and 95% of respondents agreed that they were either appropriate or very appropriate. We then further parsed this question by asking experts to list the variables they would consider core and the variables they might consider supplemental for each of these purposes. These questions were asked as open text boxes, resulting in 6 open text responses per each of our 78 experts. As you might expect, the resulting data was pretty exhaustive. These questions generated more than 26,000 words or 105 pages of responses. 2 independent raters on our team then coded the entire dataset separately using an inductive line-by-line approach. And this process yielded an initial list of 1,200 potentially distinct data domains, which we then organized, categorized, and collapsed into 329 preliminary items slotted into 6 categories and 27 subcategories. All this incredible work has been organized into an insane interactive Google Sheet where you can see how many times a variable was mentioned by participants for each of those 3 purposes and whether it was considered core or supplementary. The red and green cells here indicate high versus low frequency of mentions, and they can kind of be read as like a heat map to identify which variables have already pretty much reached consensus versus those that are more contentious. For example, we can see here that the need to report on planned number of sessions is all green across, meaning it was mentioned relatively frequently by experts across all 3 purposes. Whereas something like reporting on a patient's food and fluid intake relative to dosing was only mentioned by 1 participant as core for clinical purposes. So we can already begin to see some consensus emerge from just this initial round, and we can also see which variables we will need to get more expert feedback on to gain more clarity in subsequent rounds. Also, to quickly demonstrate the scope of this, I did a little screen recording of me scrolling, and keep in mind that each row is a unique variable that was mentioned. So the green here is intervention characteristics. Blue is participant characteristics. These are our 6 subcategories: baseline assessment, safety monitoring and adherence, participant reported experience, and outcomes. So for round 2, which we are now just beginning to analyze, we wanted to explore how this bottom-up data compares to some pre-existing reporting guidelines, such as consort, respect, and the good clinical practice guidelines. We then presented points of overlap back to our experts and had them make decisions based on these guidelines about some of the more contentious variables that we identified. So questions in the second round generally looked like this. How much do you agree with the following proposal? An example of that would be preliminary items that correspond to consort guidelines should be classified as core for all data collection purposes. And we did that for different guidelines and asked them to rate specific variables. So this project really is trying to strike a balance between generating an exhaustive list of potential variables, and especially those that are unique to psychedelic therapy, while also not entirely reinventing the wheel of reporting practices and utilizing the hard work that has already been done by others. So overall, we are pleased to find that many of the variables that were generated in round 1 can be found in other reporting guidelines, but no one guideline captures anywhere near this exhaustive list, and we also found some variables that weren't extensively covered in pre-existing guidelines. For example, our experts came up with many adverse event variables that would be unique to psychedelic therapy and warrant detailed reporting, such as acute experiences of dissociation or post-acute manic symptoms. Overall, this close but incomplete alignment with pre-existing guidelines is a nice proof that the questions we asked in round 1 were similar to other clinicians and researchers, while also distinct enough to capture the nuances of this novel treatment approach. So we were actually very excited by these results, and particularly the Google Sheet, because it's actually very close to what we hope the end product of this project will be. So we're not simply curious about what experts think about variables, but we would actually like to use their expertise to bring structure to the Wild West of psychedelics. So our end goal is to design an online tool that allows psychedelic researchers and practitioners to essentially go to a website, enter information about their patient population, therapeutic goals, and resource constraints, and be delivered a recommended battery of questionnaires and data collection and data to collect throughout their psychedelic practice at specified time points. So ideally, this would not only improve data quality in clinical and academic settings, but it could provide some guidance and structure to those dozens of ketamine clinics that are seeming to open up every week. So through this project, we hope to begin to bring clarity to the emerging field of psychedelics and deliver the first internationally expert-endorsed framework and online tool to standardize its data collection. Thanks.
Thank you, Elisabeth, for this great presentation, and congratulations on this project that is very exciting and indeed has the potential to have significant practical impacts on how research is conducted in this space. I'm curious, maybe as an initial question to open the discussion, how did you identify the participants of the Delphi study, and how do you think this strategy shapes the kinds of responses that you got and the representativeness of the sample?
Yeah, so we tried to get a real range of academics, clinicians, the crossover that can happen between those two, and also health policy experts. And we used a snowball sampling method where we're familiar with certain psychedelic experts in the field, and so we were able to reach out to them, ask if they'd be interested in participating, and then also ask them to forward the study along to other colleagues of theirs and other experts in the field. And yeah, and ideally, we want to have this as international as possible. Our sample is definitely skewed to the US, but that also does match demographics of where research is being and therapy is being conducted with this. Yeah. I think I think it's pretty broad. We also asked we have a ton of demographic information on our experts as well. I didn't present it in this, but we put together a very extensive report showing years of expertise and age, so we can really get an understanding of the range of the quality of expertise and the kind of expertise that we have. And we've got plans to also do. We think that there might, at the end of this project, be several potential papers that can come out of it. One can even be kind of a social psychological look at whether or not experts' backgrounds and expertise influenced what variables they suggested, and almost a way to kind of look at expertise and also blind spots. If clinicians, for example, aren't thinking that things that pertain to academic research is important, or if academic researchers aren't thinking about some very important clinical considerations, and we can kind of explore broadly where blind spots in the field might exist.
Yeah, it's very cool.
Thank you.
Is there any question?
So congratulations on all the hard work, really just took a lot of time. So to follow up on the question that was just asked, I think the second, or one of the second highest respondents were non-psychiatrist MDs.
Mhm.
And I'm curious, what specialties did they come from?
Yeah, I do. I have the tab of the report open. We can actually, if we've got enough time, I can even just take a little look at that. Yeah, I'll try this. I've also got both Sarah and Kyle here if you guys would like to weigh in on if that, yeah. Yeah.
Migrated the Arlington. And it had expertise. GPs are
Yeah, I don't. We've got emergency medicine as one, but it's true we don't have too many of. Yeah, medicine except psychiatry, but I don't know if we went into. I think that was an open text option that they got to write too. So if they wrote anything more specific like anesthesiology, then we have that data. But yeah, so that's another thing too is we might not have as granular as data for each specific participant as maybe would be cool to look at. But thank you. Yes.
a little Wild West.
Yeah.
Of 2,500 clinics. Are there different reports called, you know, what the uses might be or the downsides? Why you need to standardize? Why it's
I can't pull off the top of my head statistics of specific issues. That article did identify in the tagline, they make an effort to say that like the safety procedures aren't uniform across either. And I guess the kind of issue with the Wild West is exactly that actually, that we don't even have the data on the adverse events that are happening and the specifics of what kind of challenges, like the challenges could range from anything of you're an individual with treatment-resistant depression and you didn't get anything out of therapy and you're struggling just as much as you were versus, you know, physiological issues and acute issues, as we said, like dissociation during it, and that can go short and long term, etc. The point being that we actually don't have data on the specifics of that. And yeah, and I think too that especially ketamine therapy could really benefit from like some PR with that. Like for a lot of people, their introduction to ketamine therapy was, or the idea of ketamine as a therapeutic thing was introduced by Matthew Perry's death a couple years ago. And like, I think it kind of warped this idea of what the potential dangers are with these medicines, what the potential benefits could be. And it would really benefit from just good, clear data to be able to show people.
Do you want to check just to make sure if there's any question? Which...
I would love to if I knew how.
Oh yeah.
Cool.
No, we're good. Well, if there's no other question, thank you, Elisabeth, for this wonderful presentation, and to Geneviève as well. We had a wonderful rounds today, and thanks to both of you.
Sweet, thank you.
Thank you.